As you can see, this coping has 3 vertical indentations with minimal undercuts for easy repositioning of the coping after the impression is captured. As you can see, these copings are taller than the closed tray copings. Make sure your patient can open wide enough to be able to place and remove this style coping. Today I will show you a case where we are going to restore an implant that was previously placed at site number 19. Although the implant had great primary stability, it is a posterior implant in a non-aesthetic zone. Therefore, at the time of implant surgery, like many of us do, we placed a low-profile stock healing abutment to help limit shear forces on the healing implant. Let's take a moment to understand the emergence profile that has been created by this stock healing abutment. Impression copings are used to transfer the position, angulation, and connection feature orientation of the seated implants when captured in an elastomeric impression. Impressions may be taken with either the indirect closed tray or direct open tray technique, depending on the clinician's preference and chairside conditions. On this patient, a tapered implant, 5 mm in diameter, was placed at site number 19. The platform size and/or diameter of the implant placed is information you will need to order the subsequent restorative copings and abutments. In this first scenario, the closed tray or indirect 5 mm impression coping is secured to the implant by engaging the internal connection and hand tightening into place. As you can see, this coping has 3 vertical indentations with minimal undercuts for easy repositioning of the coping after the impression is captured. Radiographic confirmation is recommended to ensure there is no interferences of hard or soft tissues and the coping is fully seated. Once seated, the adjacent contacts are evaluated and adjusted if needed. Here we can visualize nice broad contacts and a great path of insertion without the need for adjustment. For this example, I took it a step further to customize the emergence profile of the impression copings by adding flowable composite. This will prevent soft tissue collapse, allowing the transfer of the soft tissue profile that was created either with a custom healing abutment or provisional restoration. In a closed tray technique, the tray is first verified for fit. The area is dried and a small piece of wax is recommended to be placed over the top of the screw head. A lighter viscosity PVS material is syringed intraorally around the soft tissue and adjacent teeth, while the tray is filled with a heavier viscosity PVS material. In this example, I used Capture medium body PVS in the syringe and Capture heavy body PVS in the tray. For implant impressions, a rigid material is recommended, such as a polyvinyl siloxane or polyether. PVS or polyvinyl siloxane is moderately rigid, has good elastic recovery, good tear strength, and is dimensionally stable, which makes this a great choice for closed or open tray impression techniques. After the impression material sets, the tray is removed from the mouth. Then the impression coping is removed. The implant analog should be attached to the impression coping before it is reinserted into the impression. As the clinician, you do not have to reinsert the coping. Instead, you can send it to the lab along with the impression, and the laboratory technician can attach the analog and seat the coping before the model work is completed. In this second scenario, the open tray or direct impression coping is secured to the implant by engaging the internal connection and again, hand tightening into place. This style coping will be removed from the mouth at the same time as the impression tray. The open tray impression coping has various undercuts to ensure it stays stable within the impression. This style coping also comes with a long guide pin that should be utilized during this impression. This allows the top of the pin to pop out through the impression tray for easier identification and removal. Again, radiographic confirmation is recommended to ensure there is no interferences of either hard or soft tissues and that the coping is fully seated. This is my impression technique of choice, as the coping stays in the impression, leaving less room for error. However, as you can see, these copings are taller than the closed tray copings. Make sure your patient can open wide enough to be able to place and remove this style coping. Once the open tray impression coping is seated, the adjacent contacts are evaluated and adjusted if needed. Same as before, you can visualize nice broad contacts and a great path of insertion without the need for adjustment. In this example, the emergence profile of the impression coping was again customized by adding flowable composite. As a reminder, this will prevent soft tissue collapse, allowing the transfer of the soft tissue profile that was created either with a custom healing abutment or provisional restoration. In an open tray technique, the tray is first verified for fit and to identify the location of the impression coping. The tray will have to be adjusted to allow the top of the impression coping to pop through. An acrylic burr is utilized to create a perforation in the tray. the tray is tried in again to ensure the impression coping is coming through the center of the hole. After verification, I like to add a piece of blue wax over the top of the hole to help hold the impression material in place. This wax makes locating the top of the coping much easier. Now we are ready for our impression. Just as with the previous technique, a lighter viscosity PVS material is syringed intraorally around the soft tissue and adjacent teeth, while the tray is filled with a heavier viscosity PVS. Keep in mind, for an open tray technique, either a polyvinyl siloxane or polyether material can be utilized. Polyether is much more rigid compared to polyvinyl siloxane, so be sure to mind any undercuts that are present in the arch when using this material. As the impression material sets, I like to locate the top of the guide pin by pushing on the blue wax with either my fingertip or the handle of the mouth mirror. After the impression material is fully set, the guide pin is completely unscrewed before the tray is removed from the mouth. Once it's removed, take a look at the impression. You can see the impression coping stayed in the tray. No need to reinsert the coping afterwards. The implant analog can then be attached to the impression coping either by the clinician chairside or by the laboratory technician prior to model work being completed. In areas where there is ample keratinized tissue, like in this situation, I am going to use the laser to remove the tissue that is covering the implant instead of displacing the tissue to the side.